Welcome to UofL Today with Mark Hebert. I hope if you've been listening to this show throughout the last couple of years that you've learned something, and perhaps we'll stick around for the next half hour and learn something today. On the show today, you may have heard the term Black Death or the plague talked about in terms of medieval Europe. Did humans learn anything from that pandemic that killed thousands? A UofL anthropology professor will be here to talk about it. And little kids who are brought into the emergency room with burns are often misdiagnosed as having burns that were an accident. A study by some UofL faculty has found that oftentimes those burns are the result of child abuse, and we will talk with them about that study. But first, mass shootings, disasters on airplanes, tornadoes that killed dozens in one area. Those are all scenarios the UofL Medical School students are seeing as part of a unique academic program called Disaster Medicine. Madison, Kommor, and Bethany Hodge are both with the UofL School of Medicine, and they are here to tell us about it. Madison, Bethany, good to see you again.
Good to see you too.
Yeah, thanks for having us.
And congratulations, Madison. You're graduating from UofL Med School, correct?
That's correct.
And going to?
I'm going to Ohio State for emergency medicine residency.
So you're doing the emergency medicine gig, huh?
I am.
Well, good for you. All right. Well, you were the one that kind of got the disaster medicine thing rolling. Bethany's kind of taking it from there. So why don't you tell us what the disaster medicine certificate program is at the University of Louisville? Let's start from there.
Sure. So the Disaster Medicine Certificate Series is an extracurricular voluntary certificate series that allows medical students from second year up until fourth year to learn about different aspects of responding to disasters and providing emergency medical care that is not already in the traditional medical school curriculum. So basically, if you wanted to learn to be a registered responder, if something were to go down in the city and you wanted to be able to rush to the scene or rush to the hospital to be able to help, you need a certain skill set to be able to do so and do so correctly. And we do our best to bring those skills to our students outside of the medical curriculum.
Such as, Bethany?
So we have a lot of different components to it where we're interacting with community entities that are already in place to handle all these things. So a lot of it is just learning the lingo of
like EMS, fire, police.
All of SWAT, all of those guys. We hang out with all those cool guys. Learning their lingo, learning the structure of command, learning the role of a physician and the place of a physician in disaster, and some, appreciation for things that may get touched on in the medical curriculum but aren't a big focus, like bioterrorism. Certain types of injuries, but it's a lot of how can I be helpful and not get in other people's way.
So give me some of the scenarios that you put these students through that have gone through this disaster medicine program.
Sure. So during our first year, probably the coolest thing that we did is that Delta Airlines gave us.
Yeah, that was cool. I was on that plane. That was really cool.
Yeah, they gave us one of their.
Tell folks what that was.
They gave us one of their jetliners to practice in-flight emergencies on. So we set up a bunch of various skill stations throughout the plane. Including, somebody's having an allergic reaction, somebody's overdosed in the bathroom, somebody's having a heart attack, things like of that nature, and figuring out how to maneuver in the small space of the plane, and then figuring out who's actually in control, who's going to be grounding the plane if you have to ground the plane, when's the right time to ground the plane, and basically giving our students confidence to be able to stand up and say, I'm not a doctor yet, but if nobody else is on the plane, I can confidently handle this situation.
Right, and what's available on the plane to use as like a stent or a needle or something, right?
Exactly.
A lot of the focus of this curriculum has been experiential because of those sorts of issues. It's all fine and dandy to learn what the right answer is for a multiple choice question on a test, but when you're in the situation, you're dealing with physical constraints, you're dealing with psychological stress, you're dealing with sort of out-of-the-box scenarios. The students want to have a little bit of preparation for those types of experiences because they expect them to happen sometime in their lifetime.
All right, we're talking with Madison Kommor and Bethany Hodge, both with UofL School of Medicine. We're talking about the disaster medicine program at the University of Louisville. So you also had a scenario of mass shootings, right? What else? Anything else? You had something downtown, some big exercise with the police and with the fire,
That's correct.
et cetera, down the health sciences campus, right?
That's right.
So what was that?
So
what'd you learn?
Oh God, what? There's a lot to learn from that for sure. But we did an active shooter capstone scenario with almost over 10 community partners, including the FBI, Department of Homeland Security, Louisville Metro SWAT, Fire, Emergency Management Agency. Basically, anybody who already does this for a living was there to play with us down at UofL. And essentially what we did was we simulated a bomb going off during an exam, along with two active shooters entering the building and shooting at faculty and staff and students as well. So we set up the scenario in which we had 40 live medical student participants with full movie makeup and injury patterns lying sprawled out throughout the building, and then the Louisville Metro SWAT team, along with UofL police and other members of law enforcement, stormed the building, neutralized the shooters, and then our job was to teach our medical students, how are you going to set up an emergency treatment area that also has a bit of a hazmat decontamination component, and triage all of your students correctly, figure out who needs to be treated first, who can wait.
Quickly, because you're the first ones on the scene.
That's correct. So like emergency personnel like EMS are going to be the first people on the scene.
Well, not necessarily. If you got a student and it's happening in a classroom on the health sciences campus,
right?
The UofL medical school students, the first guy or
that was actually one of the lessons, though, too, for students who are playing the roles of victims, is to how to act in a situation to let SWAT do their job, do those other guys. Don't rush in and be a hero unless there's indication that there's no one else coming, I guess. But again, how to act properly and not get in anybody's way. That's a big focus.
Okay,
absolutely.
So that was a big lesson learned.
Yeah.
Oh, absolutely. I mean, basically, to teach our students, you don't exactly know how you're going to react in that kind of situation. So how can you find a place in which you are safe, you are in a safe area, so that you can still administer care? Because if you're still in the hot zone where there's bullets flying around and you get injured, you can help no one, right? So if you're able to extricate yourself from the building and then come back in a specific area that's safe, you could probably save 2, 3, 15 lives, you know what I mean, instead of rushing in and being the hero. So that's kind of one thing that our students didn't realize is, wow, I get really, really scared when gunshots are going off around me. And I think any human being would. But you can't do that unless you simulate. And that was one of the big successes of our drill.
Talking with Madison Kommor, who's getting ready to graduate from UofL School of Medicine, and Bethany Hodge, who works at the UofL School of Medicine. And we're talking about this disaster medicine. And it's a certificate, and it's voluntary. So what does that mean? Students have to sign up for it, but they don't get any credit for it, or what? How's that work?
Basically, they get brownie points and stars. No, there's no curricular precedent for this. There's nobody else that's doing this, and there's no set competencies. So my job as a faculty member was to say, okay, the students are interested in this topic. How can I get them good educational experiences in this area that would have real-world validity, which is why we're using actual FEMA modules for our teaching. We're using our community partners and their real-life work so that when students go to interviews and say, hey, I've learned things about disaster medicine, it's not just from a textbook or from a PowerPoint. We've exposed them to the real-world things. Because there's no set curriculum for this, we kind of got to make it up as we went along, and we've been perfecting it since then. And it's voluntary. It's not part of the required medical curriculum. We kind of think that it would be handy or a good thing for the world if it was. But until that time, we've got these opportunities for all kinds of students that are interested.
Mm-hmm. And how many students have gone through it? Well, you've had it for 2 years?
We've had it for 2 years, and right now we're right around 120 students total in the program, and we're just graduating our first class. So of the fourth year med students that are graduating, there's probably 15 or so that have completed all the requirements, but over the course of 2 years, the requirements have changed as we refined our program. Mm-hmm. And I think what's interesting about this is that I think most people listening at home would probably say, well, of course doctors know how to do this. But the fact of the matter is, it is in very few, if any at all, medical curriculums across the United States that are teaching doctors how to respond in a disaster. So the students doing this in a voluntary fashion show that they want to learn this. They think this is part of the job. We're just the only people in the published world that have a program to let them do that.
So UofL's way out in front on this one.
We think so, and I think it's also been interesting to see, as a attending physician perspective, I think a lot of us think, oh, the emergency room will handle that. I don't need to know that because I'm an ophthalmologist or I'm a dermatologist or something like that. But what we found is that students going into all specialties feel like they should know these types of things, and I think that'll make a better workforce in the future if we have a lot more physicians who are disaster aware, so that if you are a dermatologist but you're in an area where something is going on, you can be helpful, and that all medical training, it can be useful when needed.
And isn't part of the training that this is out of the box? I think you've said before, it's when the lights go out in the hospital.
Medicine when the lights go out.
Medicine
yeah.
when the lights go out,
Right.
and you're stuck, in a situation where you just don't have all the tools. You don't have the scalpel. You don't have the, any way to check the blood pressure.
And it's a different way of approaching medicine in general. I think, if you're in a mass casualty scenario, we don't do CPR when there's multiple casualties because you can save 4 people in the time that it would take to save 1. And that's something that physicians are hardwired not to understand. We are hardwired to give the most for every single patient, and this kind of medicine is different.
Can we look back at the most famous pandemics in history, bubonic plague, sometimes called the Black Plague, and learn something from them in terms of our immune systems? Fabian Crespo thinks so. He's an associate professor of anthropology at UofL and has studied the plagues from medieval Europe. Fabian, welcome to the show. Good to see you.
Thank you. Good to see you, Mark, and thank you for the invitation.
All right. So you did a paper on, you called it the Black Plague, right?
Well, you can name it different ways.
Okay, so it's got different names, right?
Yeah. For me, from an immunological, a biological, normally you will call bubonic plague or you will call the plague, but the plague is very kind of open way to call different also infection diseases. So Black Death is the most common historical way to call it, but maybe we can argue that we can call it different ways, especially when we are going to try to understand the disease in the past and try to bring knowledge that we have today into the past. We need to be careful. Maybe the way that they call the disease, we need to respect their ways. Makes sense? As we are calling different diseases today, who knows if in the future somebody will rename it. But yes, you can say bubonic plague from a more now biomedical.
Well, I think that's what most people know it as they just call it the plague.
Yeah, exactly.
And it took place when? When did this happen?
Well, we need to be
Black Death, plague, whatever you want to call it.
We need to be careful about timing that, because normally if we will say Black Death is a specific, how to say, outbreak. You know that you have, for example, influenza, and you know that we put nicknames, sometimes not
Spanish
very kind of
flu,
exactly. We shouldn't be calling
H1N1.
Especially me with Spanish ancestry. I don't like to match with that, but that's okay. Yes, you're right. Spanish flu, for example, swine flu. So we put names. What do they mean? Well, maybe different reasons why we named that way, but they represent different outbreaks. Make sense? Different kind of big kind of episodes of where we have many cases, many people dying. So we put those names. Black Death means that it's one specific outbreak of what we can say bubonic plague. Makes sense? So the Black Death has a specific time. That is still we are trying to understand, because
and when is that?
Then it will be around 1346 and 1351, 52. Some people will put it like 1347, 1348. Why this kind of controversy? Because we are talking about something that happened 500, 600, 700 years ago.
Right.
So it's very difficult for us to determine. But if you want to put a kind of time, it will be between 1350s, around 1350s, if you want to say that.
We're only talking about a 5 or 6 year period here, right?
Exactly.
In Europe.
That specific
for that particular
outbreak.
one.
Exactly.
Gotcha,
the one that we
outbreak.
call Black Death.
Okay.
Well, if we are going back in time, when I was learning that, I thought that they were also calling Black Death. But if you are looking at that documents, they didn't call it Black Death. That was coming after. So they put different names.
And how many people died in that short period of time?
Well, we are still trying to kind of figure. The ballpark, depending on the area and depending on the continent. Most popular, we identify the Black Death in Europe, many reasons for that. People are saying that up to 50% of the population. If this
50% of the population
in some
in Europe?
areas you can go higher. But what kind of information do we use? Try to think that. Nowadays it's very difficult when we have an epidemic like, I don't know, an outbreak of Ebola in Africa a few years ago. Sometimes we're still trying to calculate with our technology today how many died. How can we calculate how many really died in the 1300s, for example? So the ballpark, you can say around 50, 40, but in some areas of Europe, it looks like it was higher, and in some areas was lower. That's from an immunological perspective. I like to understand why, if that epidemic was facing kind of the same kind of pathogen, in many areas, the mortality was different, but it was really, really high.
We're talking with Fabian Crespo, who is he's an anthropology professor at the University of Louisville and looks at kind of the history of these things.
Yeah.
So what should we take out of, what should we learn today that perhaps we didn't know back in the 1300s about this particular pandemic and maybe some others that, and these are the kinds of things that you study, right?
Yeah. Well, in my personal case, I like to approach this from a multiple disciplines, makes sense? So I'm a biologist, biological anthropologist, but I think that the lesson that we can learn, like how complex it is for us to understand. As a colleague, one of the leading kind of expert in the discipline, especially trying to understand plague in the past, Monica Green said that we need to approach now that kind of epidemic or pandemic as a developing, makes sense, kind of field. So we are still trying to learn how complex it was, not only from a biological, medical perspective, from a social, economical, political perspective. How much did it change? I would not say a huge continent, but a continent, not only Europe, but also Africa, Asia. So we are still trying to understand how an epidemic that, as you said before, did last only a few years, makes sense, could have changed the whole history. Maybe that's too ambitious, but we can learn in that. So maybe now we need to be careful about when we're approaching in a very lightly way, trying to think that Ebola outbreak, as I mentioned before, HIV, influenza, the only way that we will solve that is from a biomedical perspective. Don't get me wrong, I'm working with biomedical researchers, and that should be an important one. But we need to learn a lesson that when we are facing such epidemics, should be understood, or at least we need to approach it in different disciplines, historically, politically, socially, psychologically, biologically, medically. And I think that the more that we are learning about Black Death in Europe, or I would say the pandemic in Europe, Asia, and Africa, we are learning those lessons that we need to understand them from different disciplines.
Talking with Fabian Crespo, who's an anthropology, associate professor of anthropology at the University of Louisville. We're talking about the plague, or Black Death, as he calls it. We only got a couple minutes left, so I really do want to get to that question. So from your studies, have humans adapted, and could this happen again, I guess is the question. Could it happen again?
To simplify, that I like to talk now, but I would say yes, humans in some way must adjust. I would say either through their immune system, as I like to kind of study, I'm an immunologist, but also I would say from a social, behavioral, public health, you have different ways to adapt to such kind of catastrophic events. So I would say yes. We are still trying to understand who did survive. I'm trying to understand that. If you will ask me, I want to understand what your question is about differential mortality and who did survive and who didn't, but I don't want to reduce everything to the immune system. There is something else. And I would say if this can happen again, as you were asking, I don't know if with bubonic plague, what we can have is outbreaks. And we need to be careful because sometimes
there's a difference between outbreaks and pandemics.
Exactly. We can have an outbreak. U.S. sadly has a reservoir, so we have permanent presence of I would say Yersinia pestis, the pathogen, in the area of New Mexico, Arizona.
It still exists?
Yeah, the pathogen, yes, of course. And you have reservoirs. Reservoirs mean that is presently commonly in that area. And U.S. sadly, we have it here.
Wow.
As we have it in Madagascar.
I didn't know that.
Yes, in Europe it looks like we don't have far a reservoir. Look at that ironic, no? We are talking about medieval Europe, Black Death, and now we have it here. If this will be happening again in the dimensions that happened in the past, I would say, I don't know. But maybe it's not bubonic plague. Maybe we need to be concerned about other infection diseases. So the lessons that we are learning from bubonic plague, maybe we should be taking those to other kind of potential outbreaks. Especially like Ebola, as I said before, HIV, we need to understand it not only from a biological perspective, but things that we did wrong in the 80s from a social, political perspective. So I think that if you will ask me, can it happen again? It depends on many different factors. I would say I'm not so sure about bubonic plague in such catastrophic dimensions. But should we be aware about that? Yes, we should be always alert.
And you have little outbreaks of that or some offshoot of that could happen.
Exactly, because sometimes it's not only biology and medicine, it's how humans we react to these kind of things.
Thousands of kids get burned every year touching a hot stove, putting their hand too close to a fire, some things like that. But are some of those kids being brought to the emergency room with accidental burns really the victims of child abuse? Doug Lorenz is a biostatistician. Mary Gregg is a PhD student in biostatistics, and they worked on a study of accidental versus abusive burns in kids. Welcome to both of you.
Thanks for having us.
Doug, thanks for being back on the show. Mary, it's nice to meet you.
Thank you.
And what do you do? Tell me what do you do? You're a PhD student in biostatistics, right?
Yes, I'm working on my dissertation. Dr. Lorenz is my advisor.
Okay. Is he a good advisor?
He's fantastic.
Well, that's good to hear. All right. So you two worked on this study trying to figure out kids who are brought to the ER, I guess, right? Mm-hmm. They come in with burns. How do you discern whether they are, accidental or the result of child abuse? So tell me about the study.
Well, this was conducted at Lurie Children's Hospital out of Chicago, who we have collaborations with here at UofL. Essentially, they looked at their burn registries at the hospital and were able to identify 110 kids with burn injuries that also had been evaluated by what they call their multidisciplinary team for abuse. So one of the things that needs clarification for this paper is that 38 out of these 110 kids were abused, but this is a cohort that is already suspicious for abuse. Okay. So the prevalence of abuse in burned kids is not 35%, but out of the suspicious kids, that's what the prevalence is.
Gotcha.
So they collected the data from these kids about the characteristics of their burns, their demographic and social histories, and some of their other injury characteristics, and tried to see if any of those characteristics would discriminate abusive from accidental injuries.
Okay. Mary, what'd you find?
Well, we found, specific to the burn, that the location in the house where the child was burned was indicative of abuse. Specifically, children who were burned in a bathroom or burned in a room outside of the kitchen were at a higher risk of abuse.
Okay. So how'd you determine that, though? I mean, how'd you tell? Well, that kid's, Dad walked in with him and said, he burned himself in the bathtub. I put him in too hot of water. Oops, sorry. It was an accident. How do you determine whether that was abuse or how'd you go through all that stuff?
Well, that was where the site in the house where the burn occurred was self-report by parent.
Okay.
It's part of the standard information that the physicians gather. But what we were able to see is that specifically in the kitchen, you expect. Well, you wouldn't expect, but burns commonly occur. There are hot things there.
Hot stove, yeah.
Exactly. So over half of the kids that had been accidentally burned were burned in the kitchen, whereas only 13% of the kids that were burned in the kitchen had been abused.
Right.
And those numbers essentially flip for the other rooms of the house.
So you generally say if a kid's burned in the kitchen, chances are pretty good it was an accidental burn. Is the bottom line.
Yeah.
If they were burned in the this cohort this very specific cohort that you had, if it was in the bedroom, if it was in bathroom, someplace like that, elsewhere in the house, chances are pretty decent might have been abuse and not an accident. Is that a fair assessment?
Yes, and that corresponded with some previous reports. There are hot things in the kitchen that burn kids with a decent amount of frequency, but other rooms of the house, that's not the case.
Okay. We're talking with Doug Lorenz and Mary Gregg. They're both in biostatistics at the University of Louisville. And this was a study that was done, you said it, in Chicago at a hospital, right?
Yes.
And there were others who worked on this report as well, right? So you had some other folks from other universities, I guess, that worked on this study?
Yes. Our other collaborators, were part of the child abuse team at Lurie Children's Hospital, Norel Rosado and Elizabeth Charleston.
Okay. And Mary, UofL Hospital has a similar, don't they? The University Hospital has a similar team that looks at these abuse cases as they come in, if I'm not mistaken, correct?
That is, yeah.
I think they do have every case that comes in, they kind of take a second look at them, correct? So how does that work? When you were working with these folks in Chicago and you said that the team took a look at it, I bring my kid in, they've got a burn. How does it work from as soon as I walk through the emergency room door? Who decides, A, how to treat it, and B, whether it's potentially a case of abuse and somebody else needs to be called in? How's that work?
Well, the onus is largely on the physician and other individuals that are treating the patient. The characteristics of the burn typically they collect that information with an end to treating the injuries that the child has. But some of the other information that they gather that's not necessarily incidental to the burn, but incidental to the incident that caused the burn. Who was watching the child?
Right.
What room in the house did it occur? And those are actually some of our other results that Mary can speak about. There are things that weren't burn related that were red flags as well.
All right, that's what I was just going to ask about. So there
Absolutely.
are other factors other than the room in the house. It's
Yes. So we found that who was watching the child at the time of the incident was important. Specifically, if the child was under the care of a paramour of their parent, that is a boyfriend or girlfriend, they were at a higher risk of abuse. We also found that if there was a delay in seeking care, so if the patient presented to the ER greater than 4 hours since the time of the incident, they also were more likely to have been abused, as were if they presented and they had other skin signs such as bruising.
Okay, well, that would be obvious if they
Right.
had something else. But the other thing I think was interesting is when you're saying if you got a boyfriend or a girlfriend or a stepdad, was that in the same category or not?
No, the step parents were considered a different category.
A different category.
Yes.
And where did they fall? And were they?
So we divided the caregivers into three categories: paramour, so boyfriend, girlfriend, parent themselves, or other, and that would include step parent or a babysitter or something else.
So I assume parents less likely to abuse. What were the step parents or others compared to the boyfriend girlfriend?
There was no significant
No significant difference. Well, that's interesting. To me, that's interesting because you hear these stories a lot about stepmother, stepfather, being accused of abusing the kid. So in this case, you're saying, at least of the ones that were brought to this emergency room with burns in Chicago, that was not the case, right?
And part of that was a necessity, since this was a smaller data set of just 110 individuals. That other category was kind of a catch-all, and it includes not just step-parents and babysitters like Mary said, but also kids that may have been burned at a daycare center. So there's we weren't powered enough to be able to detect anything about step-parents. And I should mention that this categorization that we engaged in, where we separated out the paramours, was based on some significant findings that we've had in other research and things that were in the literature, that boyfriends and girlfriends, paramours, as we call it in the paper, are at very high risk for abuse.
Mm-hmm. Okay. Again, we're talking with Doug Lorenz and Mary Gregg, Mary Gregg's a PhD student in biostatistics at UofL. Doug Lorenz is a biostatistician at UofL. And we're talking about this study that they did on kids who were burned and were brought to the emergency room. Was it an accident or was it child abuse? And they did a study on that. So what can we learn, and what should we take as parents, as doctors, as others? What should we take from this study?
Well, as the primary message probably goes out to physicians. There are questions that they should be asking about the nature of the burn and the characteristics of it. Specifically, these 4 things that we found in this paper. If they've waited to come seek care, then that's a red flag. If the child is bruised in addition to being burned, that's a red flag. If a paramour was watching, then that's a red flag. And if they were burned outside the kitchen, that's a red flag. Those are questions that they should certainly ask. The message to parents is, when you present to the hospital, particularly those where an accident has occurred, when you present to the hospital, make sure you provide as accurate information as possible. This actually relates to a personal story of mine. My son was injured on a trampoline, and it happened to be my fault. He was asking me to bounce him, and he flipped and planted his fingers and broke 3 of them. He was, yeah, exactly. We were asked, actually, he was specifically asked by 4 different personnel in the emergency room about how the accident occurred and whose fault it was. And because I'm familiar with child abuse research, I knew that they were just doing their job and doing an assessment for abuse. Right. And that the parallel here is that when there is an injured or a burned child, it's important that this history is developed about how the burn occurred, and that it's confirmed multiple times, so that the information is accurate and communicated properly.
Right. And Mary, is this your first dabble in research that you got to do as a PhD?
It is not my first dabble in research, but it is my first experience with child abuse research.
And what do you think when you put this all together?
It was an interesting experience to go through the data itself because as a statistician, you are so far removed from the human aspect of it. And I remember distinctly going through the data, cleaning it up, starting to analyze it, and coming across there was one patient in this data set that actually died. And I'd never really felt something looking through data before, but when I saw that, it really took me a second to be like, this is real.
There's a real person behind that, that data set. Yep, there is. All right. Well, I appreciate you both being on the show. Thanks for listening to UofL Today with Mark Hebert, and go Cards.